Good morning, everyone. Bonjour tout le monde. Aujourd'hui, je suis avec ma collègue, la ministre Hajdu et le ministre Miller. Et évidemment, la Dr. Tam, le Dr. Njoo et le Dr. Wong sont aussi avec nous à Ottawa. Yesterday, we had a great meeting with Canada's First Ministers. And as the Prime Minister said, we continue to work collaboratively today and tomorrow on the priorities of Canadians, including, obviously, the continued fight against COVID-19 and the federal, provincial, territorial collaboration in terms of healthcare, vaccinations, and the other important priorities that Canadians have asked us to continue to work collaboratively on together. Je tiens à remercier tout particulièrement tous les médecins, les infirmiers et leurs équipes pour les heures qu'ils consacrent à travers le pays à aider les Canadiens et à lutter contre la COVID-19. I know that this is a Team Canada effort in the coming weeks as we focus on the delivery of vaccines. We know how important this delivery is, and it is why the Government of Canada, as we told the premiers yesterday, will incur 100% of the cost of the vaccines, the logistic, the transportation necessary to ensure that every Canadian can have access to a vaccine for free. And I would now like to turn to my colleague, Patty Hajdu, to say a few words. Patty.
Merci, Dominic. Un beau matin. On a eu cette semaine de bonnes nouvelles concernant le vaccin. Comme tout le monde au pays, je suis heureuse que l'on puisse bientôt commencer la vaccination suite à l'approbation de premiers vaccins contre la COVID-19. Par contre, les chiffres que Dr. Tam et Dr. Njoo vont présenter dans quelques instants sont clairs. On continue de faire face à une augmentation rapide du nombre de personnes qui ont la COVID-19. Malheureusement, cette hausse veut aussi dire une augmentation du nombre de décès. So as I've said in French, we had some good news this week with the arrival of an effective vaccine, the approval of an effective vaccine, but we are not out of the woods yet. And Dr. Tam and Dr. Njoo shortly will illustrate the newest modeling that will highlight the fact that COVID-19 is still presenting a very clear danger to Canadians all across the country. We know that the vaccine is an important part of the solution in stopping spread and reducing deaths, but we have a lot of work to do together as a country in the next several months. And so I'm encouraging people to continue to take care of each other, to follow the public health advice that we all know so well, to stay close to home, to stop gathering, to reduce our contacts, and to wear a mask whenever we are in close contact with others and out in public. Also, to make sure that you download the COVID alert. This is a very useful tool, as we have seen across the country. It is a way to help the public health officials that are working so hard to do that contact tracing and protect all of us as we come into contact with one another, even casually. As I said to my children, it's also a great way to protect the people that you care about, even anonymously. So my message today to Canadians is that we're entering into a very tricky period of time. Of course, it's the holiday season. Many of us are looking forward to a rest from our workplaces and an opportunity to have some downtime. But we're going to have to be very, very cautious during the next several weeks to protect those people who are counting on us to work together. Thank you very much.
Thank you, Patty. And now, Marc Miller.
Kwe Ulukut Tanse, hello, bonjour. 2 days ago, Health Canada approved the Pfizer vaccine, and this is encouraging news. However, First Nations, Inuit, and Métis have historically endured and continue to endure systemic racism and discrimination when seeking healthcare, resulting in mistrust in Canada's healthcare systems. We will continue to work with partners to increase cultural safety and respect for Indigenous peoples when planning the COVID-19 vaccine and addressing the hesitancy that is around it. The COVID-19 Vaccine Working Group at Indigenous Services Canada works collaboratively to provide an integrated and coordinated approach to support the administration and planning of process of COVID-19 and vaccine in communities. The logistics of a COVID-19 vaccine will require coordination with Indigenous communities, provinces, territories, and other partners. Les Premières Nations, les Inuits et les Métis ont historiquement subi et continuent de subir les conséquences du racisme et de la discrimination systémique. Ce racisme ainsi que les expériences troublantes vécues par certains entraînent une méfiance justifiée à l'égard des réseaux de santé du Canada. La logistique derrière le déploiement d'un vaccin contre la COVID-19 exigera une coordination et une collaboration avec les communautés autochtones, les provinces, les territoires et d'autres partenaires. The vaccine is encouraging news. However, I must remind everyone to stay vigilant. And Tom, my Chief Medical Officer, will go through the numbers in Indigenous communities shortly. This will be a difficult month for many, series of months, in fact. The colder months mean spending more time indoors and also mean higher risk of spreading and getting COVID-19. We see this trend already across Canada, across all populations, and I can't stress enough the importance of following the public health guidelines. Those measures are in place because they work and they save lives. We've seen recent outbreaks in remote and isolated communities and recent increases in cases. They're extremely alarming. We must anticipate and prepare for more in the coming weeks. It's crucial that we get this right as the second wave of COVID-19 pandemic encroaches on Indigenous communities across the country. In the past few days, the communities of Shamattawa and Manitoba and Fond du Lac and Saskatchewan have requested the help of the Canadian Armed Forces to work alongside members of the communities and provincial partners to address immediate needs. As the situation develops, we will continue to assess the requirement for military support in the area through on-the-ground reporting in coordination with our whole-of-government partners, including Public Safety and Indigenous Services Canada. One thing that's been reinforced over the past several months is this. When local Indigenous leadership have the necessary resources, they are the most successful in responding to the crisis with immediate, innovative, and proactive measures to ensure the safety of their people. This is the driving force, among other things, behind the Indigenous Community Support Fund, which has been designed to provide the maximum flexibility so that funding could be directed to where it's most needed. Jusqu'à présent, nous avons investi plus d'1 milliard de dollars dans le fonds de soutien aux communautés autochtones pour un total de 4 milliards en soutien direct aux communautés autochtones. Ce fonds a joué un rôle important en promouvant la sécurité alimentaire, en améliorant les services de soutien en santé mentale et en assurant la distribution d'équipements d'urgence, ce qui permet de répondre à vos priorités, à vos rythmes dans les communautés. We know there is a lot more work to do, and we will continue this work in true partnership with First Nations, Inuit, and Métis to achieve our objective. Miigwech, Nakumik, Marcy Cho, thank you, et merci.
Merci beaucoup, Marc. On va tourner maintenant au Dr. Wong.
Good morning, bonjour. I want to acknowledge that I'm on the unceded territory of the Algonquin people. As of December the 10th, a total of 5,675 First Nations on reserve COVID cases have been reported, with 2,100 having active infection. It is distressing that the number of active cases has doubled in the past month, and the current number of active cases is over 20 times higher than the peak number during the first wave of the pandemic for First Nations on reserve. Sadly, there have been 49 on-reserve fatalities. This is in the context of over 13,000 deaths in Canadians. The recent surge in cases and deaths in the general Canadian population and in Indigenous people is heartbreaking. We must do everything we can to protect our elders from this COVID pandemic. We need to listen to the evidence-based advice of the National Advisory Committee on Immunization about the need to prioritize frontline healthcare workers, long-term care settings, seniors, together with Indigenous peoples who are disproportionately impacted by COVID-19. It is imperative that First Nations, Métis, and Inuit be partners in the co-planning for culturally safe and equitable access to the vaccine in both rural, remote, and urban areas. We need to walk down this path together so that no one is left behind. Miigwech, Nakumik, merci, and thank you.
Merci beaucoup, Dr. Wong. Thank you. We'll now turn to Dr. Tam and Dr. Njoo.
Bonjour, good morning. Today we are going to be providing an update on the national epidemiology and modeling work. Currently, there are over 73,200 active cases in Canada, up from 52,000 just 3 weeks ago. Despite over 440,000 cumulative cases, just over 1% of the Canadian population has tested positive for COVID-19 to date. This is an important reminder that the vast majority of Canadians remain susceptible to infection.
Bonjour à toutes et à tous. Aujourd'hui, nous ferons le point sur les travaux d'épidémiologie et de modélisation effectués au pays qui orientent la gestion actuelle de la COVID-19 au Canada. À ce jour, on totalise plus de 73 200 cas actifs au Canada, comparativement à 52 000 il y a à peine 3 semaines. Malgré le fait que nous ayons atteint plus de 440 000 cas cumulatifs cette semaine, un peu plus de 1% de la population à travers le pays a reçu un résultat positif à ce jour. Ceci est un rappel important du fait que la grande majorité des Canadiens et des Canadiennes demeurent à risque de développer l'infection.
So the resurgence of COVID-19 in Canada clearly shows that the current daily case count far exceeded the peak of the first wave. And on the average, over 6,500 cases are being reported daily. And there's little indication this upward trajectory will change without further intensifying public health measures. Notably, about 100,000 new cases have been reported across the country in just the last 3 weeks.
Diapositive 2. La résurgence de l'épidémie de COVID-19 au Canada montre clairement que le nombre de cas quotidiens actuels dépasse de beaucoup le pic de la première vague. En moyenne, plus de 6 500 cas sont maintenant rapportés chaque jour et rien n'indique que cette trajectoire ascendante va changer sans une intensification des mesures de santé publique. De plus, environ 100 000 nouveaux cas ont été signalés dans tout le pays au cours des 3 dernières semaines seulement.
Slide 3. Continuing rapid growth of the epidemic in Canada is being driven primarily by the 6 provinces west of the Atlantic region. In recent weeks, each of these provinces marked their highest daily case count, and sadly, several have also observed their highest daily number of deaths to date. Community-level public health measures have been strengthened, but we have yet to see the kind of sustained decline in daily case counts that would indicate we are bringing the pandemic under control.
Diapositive 3. La croissance rapide actuelle de l'épidémie au Canada continue d'être principalement due au taux élevé d'infection dans les 6 provinces à l'ouest de la région atlantique. Au cours des dernières semaines, chacune de ces provinces a enregistré son plus grand nombre de cas quotidiens et, malheureusement, plusieurs ont également rapporté le plus grand nombre de décès quotidiens à ce jour. Les mesures de santé publique au niveau communautaire ont été renforcées partout au Canada, mais on n'enregistre pas encore le type de baisse soutenue du nombre de cas quotidiens qui indiquerait que nous maîtrisons la pandémie.
Slide 4. Since the last modeling update, the number of health regions reporting over 100 cases per 100,000 population in dark blue has increased from 30 to 49 as rapid growth expands to more areas. Alberta, Manitoba, and Saskatchewan continue to have the highest infection rates, particularly in urban centers, but rural and remote communities are being impacted as well. Atlantic provinces, including Nova Scotia and PEI, that only recently reported community transmission, were able to quickly implement a range of public health measures to interrupt spread. Likewise, New Brunswick's quick response prevented further spread from a super spreader event, allowing several regions to return to lower-level restrictions. In Nunavut, a 2-week territorial-wide restriction period started in response to an imported case and sharp spike in locally acquired cases. This quickly reduced case counts in the territory.
Diapositive 4. Depuis la dernière mise à jour de la modélisation, le nombre de régions sanitaires signale plus de 100 cas par 100 000 habitants. Ce sont les régions bleu foncé, est passé de 30 à 49. La croissance rapide s'étendant à un nombre accru de régions. L'Alberta, le Manitoba et la Saskatchewan continuent d'avoir les taux d'infection les plus élevés, tout particulièrement dans les centres urbains. Mais les communautés rurales et éloignées sont également touchées. Les provinces de l'Atlantique, dont la Nouvelle-Écosse et l'île du Prince-Édouard, qui ont tout récemment signalé une transmission communautaire, ont mis en œuvre rapidement une série de mesures de santé publique pour interrompre la propagation. De même, la réaction rapide de Nouveau-Brunswick à un événement de superpropagation a prévenu une propagation additionnelle et permis à plusieurs régions de revenir à des restrictions de niveau inférieur. Au Nunavut, une période de restriction de 2 semaines appliquée sur l'ensemble des territoires en réponse à une importation, à une forte augmentation de cas acquis localement, a rapidement réduit le nombre de cas dans le territoire.
Slide 5. The percentage of people who test positive for COVID-19 is another important indicator to monitor how hard we're looking to find cases and to gauge how much the virus is spreading. Based on the WHO international benchmark, countries should aim to keep the percentage positive to under 5%, as anything above this would indicate we're not testing enough. The average percentage of people testing positive in Canada has been increasing for many weeks, and the national percent positivity remains above the benchmark at 6.5%. As well, spikes of up to 10% or higher test positivity in several provinces signal a need to increase testing to detect and isolate a growing number of cases in the community.
Diapositive 5. Le pourcentage de personnes obtenant un résultat positif pour la COVID-19 est un autre indicateur important permettant de monitorer à quel point nous cherchons à trouver les cas et à évaluer à quel point le virus se propage. Selon le document de référence international de l'OMS, les pays devraient viser à garder le pourcentage de positivité sous les 5 %, tout pourcentage supérieur étant susceptible d'indiquer que nous ne testons pas assez. Le pourcentage moyen de personnes ayant obtenu un résultat positif augmente au Canada depuis plusieurs semaines et se situe maintenant au-dessus du pourcentage de référence à 6,5 %. De plus, des pics allant jusqu'à 10 % ou plus de positivité des tests dans plusieurs provinces indiquent qu'il est nécessaire d'augmenter le nombre de tests pour détecter et isoler un nombre croissant de cas dans la communauté.
Slide 6. Across Canada, the incidence of COVID-19 has been consistently high in all age groups for many weeks. However, incidence is highest and continuing to escalate among adults 80 years and older who are at high risk of severe outcomes, including death.
Diapositive 6. D'un bout à l'autre du Canada, l'incidence de la COVID-19 a été élevée, et ce, de manière constante dans tous les groupes d'âge depuis plusieurs semaines. Cependant, l'incidence est plus forte et est en augmentation constante chez les personnes de 80 ans et plus qui sont à risque élevé d'issues de santé majeures, incluant le décès.
Slide 7. Ongoing high rates of infection in communities continuously leads to new infections, more and larger outbreaks, and spread into schools and high-risk settings such as hospitals, long-term care facilities, correctional facilities, and shelters, where spread is further amplified in closed settings. In particular, as community transmission has intensified, there have been an increasing number of outbreaks in long-term care facilities, ranging in size from a few cases to over 100. This is a difficult cycle of spread that can't be managed through outbreak response alone. Bringing infection rates down to stop the spread into these high-risk settings requires individual and public health authorities working together.
Diapositive 7. Les taux d'infection constamment élevés dans les communautés mènent continuellement à des nouvelles infections, à des éclosions plus nombreuses et plus importantes, ainsi qu'à la propagation dans les écoles et dans les milieux à haut risque, tels que les hôpitaux, les établissements de soins de longue durée, les établissements correctionnels et les refuges où la propagation est encore plus amplifiée dans ces espaces fermés. Plus précisément, étant donné la transmission communautaire qui s'est intensifiée et qui atteint des hauts taux d'infection, il y a une augmentation du nombre d'éclosions dans les établissements de soins de longue durée, allant de quelques cas à plus d'une centaine. C'est un cycle de transmission complexe qui ne peut être géré par une seule réponse aux éclosions. Réduire les taux d'infection pour arrêter la propagation dans les écoles et les milieux à haut risque nécessite que les individus et les autorités de santé publique travaillent ensemble.
Slide 8. The spread to Indigenous communities is another concerning trend, as Dr. Wong had already indicated. For example, as of December the 7th, Indigenous Services Canada reported a total of over 5,550 confirmed cases on First Nations reserves to date, including 2,080 active cases. 85% of the cases to date have been reported from the 3 prairie provinces. These case counts include several large outbreaks in Indigenous communities across the prairies and some small communities that are experiencing very high rates of positivity. The burden of COVID-19 in First Nations peoples is higher off reserve. As another example, Nunavut only recently reported its first locally acquired cases, which rapidly led to larger community outbreaks.
Diapositive 8. La propagation aux communautés autochtones constitue une autre tendance préoccupante. Par exemple, en date du 7 décembre, un total de plus de 5 550 cas confirmés dans les réserves des Premières Nations a été rapporté par Service aux Autochtones Canada, incluant plus de 2 080 cas actifs. 85% des cas ont été rapportés par les 3 provinces des Prairies. Ces cas comprennent plusieurs grandes éclosions dans les communautés autochtones des Prairies et certaines petites communautés qui connaissent des taux de positivité très élevés. Le fardeau de la COVID-19 dans les communautés des Premières Nations est plus élevé en dehors des réserves. À titre d'exemple supplémentaire, le Nunavut rapportait seulement récemment ses premiers cas acquis localement qui ont rapidement mené à des éclosions communautaires plus importantes.
Slide 9. Hospitalizations have been increasing for many weeks, following consistently elevated disease activity. Over the past week, an average of 2,900 people with COVID-19 were being treated in Canadian hospitals on any given day, including 565 of whom were in ICUs. On average, the length of stay for people hospitalized for COVID-19 is about 17 days, or about 24 days for those experiencing more severe illness. Critical care beds are at or near maximum capacity in many areas. This situation has put a strain on the healthcare system. Hospitals have had to make the difficult decision to postpone important medical procedures, which adds to existing backlogs and impacts the broader population.
Diapositive 9. Les hospitalisations sont en augmentation depuis de nombreuses semaines et font suite à l'augmentation continue de l'activité de la maladie au cours des 3 derniers mois. Au cours de la dernière semaine, en moyenne, environ 2 900 personnes infectées par la COVID-19 ont été traitées chaque jour dans les hôpitaux canadiens, incluant 565 d'entre elles aux soins intensifs. En moyenne, la durée de séjour des personnes hospitalisées pour la COVID-19 est d'environ 17 jours ou d'environ 24 jours pour les personnes souffrant d'une maladie grave. L'occupation des lits aux soins intensifs a atteint ou est presque à capacité maximale dans de nombreuses régions. Cette situation a mis à rude épreuve le système de soins de santé. Les hôpitaux ont dû prendre la difficile décision de rapporter des procédures médicales importantes, ce qui ajoute au retard existant et a un impact sur l'ensemble de la population.
Slide 10. Deaths are a late indicator of COVID-19 severity. Over the past week, an average of 100 deaths have been reported daily. Older adults are at highest risk, from deaths from COVID-19, with those aged 80 years accounting for 71% of all deaths, and those aged 60 to 79 years accounting for 26%. A majority of deaths continue to be linked to outbreaks in long-term care homes. People of any age can experience severe or prolonged illness due to COVID-19, and more than 35 deaths have been reported in adults under 40 years of age.
Diapositive 10. Les décès constituent des indicateurs tardifs de la gravité de la COVID-19 qui peuvent survenir plusieurs semaines après l'augmentation du nombre de cas déclarés. Au cours de la dernière semaine, plus de 100 décès ont en moyenne été signalés chaque jour. Les personnes âgées sont les plus à risque de décès par la COVID-19, le risque étant le plus élevé chez les personnes âgées de 80 ans et plus. Ces dernières représentent 71% des décès liés à la COVID-19, tandis que ceux âgés de 60 à 79 ans représentent 26%. La majorité des décès continuent d'être reliés aux éclosions dans les centres de soins de longue durée. Les personnes de tout âge peuvent souffrir d'une maladie grave ou prolongée due à la COVID-19 et plus de 35 décès ont été signalés chez les adultes de moins de 40 ans.
Slide 11. Based on Canadian data up to December 5th, short-term forecasting shows the predicted cases and deaths due to COVID-19 out to December the 25th, an important day. Short-term models continue to be accurate in predicting the growth trajectory. The graph on the left shows the predicted number of cases could be in the range of 531,300 to 577,000 by December the 25th. The graph on the right shows the predicted number of deaths that could be in the range of 14,410 to 14,920 by December the 25th.
Diapositive 11. Sur la base des données canadiennes, en date du 5 décembre, les prévisions à court terme fournissent le nombre prévu de cas et de décès dus au COVID-19 jusqu'à 25 décembre. C'est Noël. Les modèles à court terme continuent de prévoir de façon adéquate la prévision de la trajectoire de croissance. Le graphique de gauche montre que le nombre de cas prévus pourrait se situer entre 531 300 et 577 000 d'ici le 25 décembre. Le graphique de droite montre que le nombre de décès prévus pourrait se situer entre 14 410 et 14 920 d'ici le 25 décembre.
On slide 12, here we have the longer range forecast showing how the epidemic could evolve in Canada over the next couple of months. The forecasted number of cases for early January is lower than 2 weeks ago because more stringent controls in British Columbia and Manitoba appear to be starting to control the epidemic there. Nevertheless, bending the curve of this resurgence, the blue line trajectory, requires immediate, consistent, and strong combined efforts of individuals and local authorities in order to sufficiently reduce the current number of people we interact with each day. For all of us, that means we continue to maintain physical distancing, reduce contacts outside our household to essential activities, have good hand-washing practices, and wear face masks to protect others and ourselves. For local authorities, implementing restrictions, closures, and control measures are required to achieve the reductions in contacts necessary to arrest climbing numbers. We are forecast to have 12,000 daily cases by the beginning of January, with increasing hospitalizations and death following this rise, unless significant reductions in contact rates are achieved.
Diapositive 12. Ces prédictions à plus long terme montrent l'évolution possible de l'épidémie au Canada au cours des 2 prochains mois. Le nombre de cas prévus pour le début janvier est plus bas qu'il y a 2 semaines en raison de mesures de contrôle rigoureuses en Colombie-Britannique et au Manitoba qui commencent à démontrer une efficacité à y contrôler l'épidémie. Néanmoins, l'aplatissement de la courbe, la trajectoire de la ligne bleue nécessite des efforts combinés immédiats, constants et importants de la part des Canadiens et des autorités locales afin de réduire suffisamment le nombre de personnes avec lesquelles nous interagissons chaque jour. Pour nous tous, cela signifie que nous continuons à maintenir une distance physique, à réduire nos contacts en dehors de notre foyer aux activités essentielles et à bien se laver les mains et à porter le masque pour nous protéger et pour protéger les autres. Pour les autorités locales chargées de la mise en œuvre des restrictions, les fermetures et les mesures de contrôle sont requises pour arriver à la réduction des contacts nécessaires pour stopper la hausse des chiffres. Nous prévoyons 12 000 cas par jour d'ici le début janvier, ainsi qu'une augmentation des hospitalisations et des décès qui s'en suivront à moins que le taux de contact ne soit réduit de manière significative.
Our last slide, slide 13. Canada is at the starting blocks of its COVID-19 vaccine response. It is the best news we have heard for some time. Knowing access to safe and effective vaccines for all Canadians is within sight might lead some to think COVID-19 is no longer a problem. But the reality is very different. Canada and many countries around the world are still experiencing high infection rates. Nationally, we remain in a rapid growth trajectory. But the observed reduction in the longer-range forecast numbers since the previous modeling update demonstrates that when public health authorities and individuals work together to implement and adhere to more stringent controls, we can bend that curve. We need to rapidly reduce the strain on hospitals and our public health systems so that our health workers can keep the pandemic under management control at the same time as implementing the most complex vaccine program in our history. As 2020 comes to a close and the prospect of vaccines bring us hope, we must do everything we can to celebrate safely. With a bit of creativity and planning, we can still maintain our important traditions and social connections while keeping our families and friends safe. By now, our essential public health practices are as familiar as the layers we put on in winter, and we need to keep up with these for a while longer as we ring in the new year. Thank you.
Et finalement, le Canada est sur la ligne de départ de sa réponse vaccinale à la COVID-19. Ce sont les meilleures nouvelles que nous ayons entendues depuis un moment. Savoir que l'accès à des vaccins sûrs et efficaces pour tous les Canadiens est en vue pourrait amener certains à penser que la COVID-19 n'est plus un problème. Mais la réalité est bien différente. Le Canada et plusieurs autres pays partout dans le monde font toujours face à des hauts taux d'infection. À l'échelle nationale, nous demeurons dans une trajectoire de croissance rapide, mais le ralentissement observé, si on compare les prévisions à plus long terme d'aujourd'hui aux précédentes, démontre que quand les autorités de santé publique et les individus travaillent ensemble pour implanter et adhérer à des mesures de contrôle plus rigoureuses, nous pouvons ralentir la croissance de cette épidémie. Nous devons rapidement réduire la pression sur les hôpitaux et sur les systèmes de santé publique pour que nos travailleurs de santé puissent garder la pandémie à un niveau de gérable pendant qu'ils mettent en place le programme de vaccination le plus complexe de notre histoire. Alors que 2020 tire à sa fin et que la perspective des vaccins nous donne de l'espoir, nous devons faire tout notre possible pour célébrer en sécurité. Avec un peu de créativité et de planification, nous pourrons quand même maintenir nos importantes traditions et nos liens sociaux en gardant nos familles et nos amis en sécurité. À présent, les bonnes pratiques de santé publique qui nous sont autant familières que les couches de vêtements qu'impose l'hiver, et nous devons les garder un peu plus longtemps alors que nous célébrerons une nouvelle année. Je vous remercie.
Merci. Nous allons maintenant prendre les questions des journalistes. Une question de suivi. We'll start with 3 questions over the phone. Operator, over to you.
Thank you. Please press star 1 at this time. S'il vous plaît, appuyez sur étoile 1 pour toute question. Our first question is from Raymond Fillon. Première question est de Raymond Fillon de TVA. À vous la parole.
Merci beaucoup. Peut-être une première question pour le ministre Leblanc ou la ministre Hajdu. Le major général Fortin nous disait avant-hier que les vaccins devaient quitter la Belgique vers le Canada vendredi. C'est aujourd'hui. J'aimerais savoir si vous avez la confirmation que c'est le cas, si les premières doses sont en chemin au moment où on se parle.
Peut-être je peux débuter et soit le docteur Tam ou Patty Hajdu pourront ajouter. d'après que le général Fortin nous a confirmé hier, lors de la discussion avec les premiers ministres des provinces et des territoires, c'est que tout est en marche pour la livraison des vaccins. Il a été très clair hier à la conférence de presse que les vaccins sont en route vers le Canada. Alors, nous attendons les arrivées dès que prévu.
Merci beaucoup. Question suivie pour le Dr. Njoo, peut-être. Qu'est-ce qu'il y a de plus inquiétant dans toutes ces données que vous nous présentez aujourd'hui? Je pense qu'inquiétant, c'est le mot, mais qu'est-ce qu'il y a de particulièrement inquiétant à vos yeux, à vous?
Merci pour la question. D'après moi, c'est toujours le taux d'incidence d'infection, mais ce qu'on a vu aussi aujourd'hui, c'est aussi les indicateurs tardifs, les hospitalisations et aussi les décès. C'est vraiment il y a beaucoup de pression sur notre système de soins de santé aussi, de santé publique. Et on est presque, je pense que dans quelques régions du pays, presque à point d'être débordé. Et on a déjà reporté les procédures médicales importantes. Ça, pour moi, c'est vraiment important parce que c'est une indication des autres conséquences à part de seulement concernant la COVID-19. Donc, ça, c'est quelque chose à suivre et on espère que les indicateurs tardifs vont aussi peut-être commencer à diminuer, mais c'est toujours quelque chose à suivre dans quelques semaines. Ce qu'on fait aujourd'hui, on va voir les conséquences dans quelques semaines. Merci.
Merci, Raymond. Prochaine question.
Thank you. Merci. Prochaine question is from Dylan Robertson from Winnipeg Free Press. À vous la parole. Please go ahead.
Hi, Minister Miller. I wanted to ask about expediting vaccine quota for Indigenous people inside provinces. The Manitoba Premier said Tuesday that Ottawa has boosted the Q1 allocation of Moderna by 15% for Manitoba, that this was in recognizing the elevated risk for remote First Nations. I'm still waiting 3 days later for Health Canada to confirm if that's actually happening. The Premier also said yesterday that your government will not similarly expedite doses for urban Indigenous people. So I'm wondering if you can confirm any of this, and if you could also list which provinces are getting expedited allocations and how much we're talking about.
Thanks, Dylan. I think you're touching on a key element of our Medicare system, which is one of universality and fairness. And I would refer you back to the national guidelines that were issued last Thursday on the prioritization of populations. There's a cascade of prioritization based on essential health workers, people living in congregate living conditions, and Indigenous peoples. And you may ask yourself, what's the reason for that? Well, I think it's pretty obvious that Canadians expect our health delivery services to be fair, and we're talking about people that are in a position of vulnerability. As to answering directly your question, and I'll pass some of it over to Dr. Tom Wong. It's key as we look at the cascade of deployment and cognizant that we are in the initial phases, and we're talking about preliminary amounts that will be distributed to 14 points. You're talking about a conversation that'll be a lot more timely in short order, and I think it's important to remember that there is some time before we get effective deployment of other vaccine vectors, but it's to underscore the importance of the vulnerability of Indigenous peoples. I mean, we need only look to some of the numbers that we're seeing with our partner to the south of us to see numbers of 3.5 to 5 times greater in Indigenous populations in the United States in terms of the impact and spread of COVID. And the impact on Indigenous peoples is devastating. That is for a number of socioeconomic reasons. And the impact on the healthcare system is correspondingly quite strong. So when we're talking about urban Indigenous populations, remote and northern populations, we need people to be focused on that. And I think Canadians expect us to be focused on those numbers and the deployment of the vaccine in order to, one, protect those populations and ensure they get first care healthcare service in a country that we pride ourselves on that healthcare service and hasn't provided it to Indigenous peoples in the past, but also in urban areas where we need the partnership with the province, and that's a hand that I extend to all premiers, and including the territories, to make sure that that is deployed in a way that represents what all Canadians expect, which is a fairness in the healthcare system. As to quotas and allotments, that conversation is very early. And on that point, I'll pass it over to my Chief Medical Officer, Tom Wong.
Thank you very much for the question. From a public health perspective, the vulnerabilities of First Nation, Métis, and Inuit people, wherever they live, whether it's in the north or in urban centers, this is extremely important. One of the important aspects, is the importance of sitting down together, with the province, with the territory, with the federal government and First Nation, Métis, and Inuit partners. We walk this path together. It's only when we discuss together the plan forward that we can actually resolve, these issues about inequalities, inequities, and address, the vulnerabilities. Thank you.
If it's okay, I'll just jump in just to add some clarity. The decision has been made, and it is on a per capita basis with additional allotments for Indigenous people, so on First Nations. And so I think, Dr. Njoo, you've been involved in that conversation. Just for clarity purpose, let's be very clear here.
Okay, so certainly from the public health perspective, as I indicated earlier, I think on Wednesday, we've had good discussions, and so within the public health community, it's quite clear. I'll restate that. We're talking about 6 million doses overall for the first quarter. And what's interesting is that the combination is between Pfizer and Moderna. So 4 million doses for Pfizer and 2 million doses for Moderna. But at this point, we only have one approved vaccine, that's the Pfizer vaccine. So much of this planning is taking place with a vaccine which has not already been approved. And so as we indicated earlier, the territories have indicated to us that for their planning purposes, it's difficult. The Pfizer vaccine, I guess the term is, it's fragile. It has to be used under very strict conditions. It doesn't make sense for them to accept their allocation with the Pfizer vaccine. And so they indicated a preference to receive the Moderna vaccine once it becomes approved and once it becomes available. And of course, the shipping and the delivery schedules, that'll all have to be taken into account once that's approved. And so if you look at the territories, that's what they want. I can appreciate also then in certain provinces, especially for their maybe northern communities, it might be the same issue as it might be for the territories. And so in terms of actually figuring out the ratios, what vaccine, the timing of deliveries and so on, that's a live issue. But I think as Minister Hajdu has also indicated, at the end of the day, it's a per capita allocation. Thank you.
Do you have a follow-up, Dylan?
Thanks especially to Minister Hajdu for that clarity. I just wanted to know the numbers that we're talking about in Q1, whether that's on a provincial basis or just across Canada, if you're able to say how much of the Moderna dosage is meant to be, increased per capita over the per capita to make up for Indigenous communities. And is this strictly to uphold Ottawa's fiduciary duty to First Nations on reserve, or will this include Métis people and non-status?
Well, I think first of all, what we have to be clear is that the Moderna vaccine is not approved yet. So those discussions on how the Moderna vaccine will be distributed are ongoing. But in general, as Dr. Njoo has illustrated, it is on a per capita basis. It is with additional doses for the federal populations that the federal government are responsible for, that is people on First Nations and living in First Nations communities. But I think to reiterate what Minister Miller is saying is that we expect in urban populations that Indigenous people, including Métis people that are living within urban populations, are treated like every other Canadian in that population and have access in an equitable way. And if I can be so bold to say, I think that is what Minister Miller laid out as the expectation for all premiers and for all provinces and territories, that this is their fiduciary responsibility, or their jurisdictional responsibility in urban centers. There is no distinction, by the way, when a person lives in a city like Thunder Bay who is Indigenous or not. They have exactly the same rights to access to care and health care as a non-Indigenous person. And so I think what we all expect is that the National Advisory Committee recommendations are applied at the provincial level and done so in a way that's equitable and fair.
Thank you. We'll take one more question from the phone and then take questions from the room.
Merci. La prochaine question nous vient de Émilie Bergeron, agence QMI. À vous la parole. Please go ahead.
Oui, bonjour. J'aimerais revenir sur la diapositive 12 où vous dites que tant qu'il n'y a pas de réduction de contact, on peut pas inverser la courbe si on veut et freiner la propagation rapide. Mais comment concrètement est-ce possible pour les gens de réduire leurs contacts? On sent que vous invitez les provinces à adopter des mesures plus sévères. Est-ce que ma compréhension est bonne?
Merci pour la question. C'est Dr. Njoo. Je pense que c'est vraiment des bonnes nouvelles avec peut-être l'introduction des vaccins ici au Canada, même la semaine prochaine, mais je pense que le point à souligner, c'est très important pour tout le monde de comprendre qu'il faut continuer avec toutes les mesures de santé publique et comme j'avais déjà constaté dans les notes d'allocution, c'est toujours, comme dit, une combinaison des efforts des individus, des Canadiens et Canadiennes, et aussi les autorités, je pense plus à l'échelle locale de santé publique. Le but vraiment, c'est de limiter le nombre de contacts, et si on a des contacts avec des autres personnes, d'utiliser plusieurs couches de protection, le port de masque aussi, bien se laver les mains fréquemment, tout ça. Donc, je pense c'est vraiment à suivre à l'échelle locale. Si on voit avec l'épidémiologie que dans une région du pays, que le taux d'incidence commence à continuer à augmenter, donc il faut peut-être, les autorités locales, il faut peut-être implanter, mettre des mesures plus restrictives et plus sévères. Et si tout le monde suit les consignes et les taux commencent peut-être à diminuer, on peut-être un peu lâcher un peu ou peut-être, comment dire, regarder encore de nouvelles situations, qu'est-ce qu'il faut faire. Donc, je pense que c'est toujours une question de souligner des points. Ça va être un hiver dur, c'est sûr, parce que même avec l'introduction des vaccins, même le premier trimestre de 2021, c'est seulement au fur et à mesure on commence, comme on dit, avec un nombre de doses limitées et on espère peut-être qu'au mois d'avril, le deuxième trimestre, qu'on voit beaucoup plus de vaccins disponibles pour offrir la vaccination à plus de Canadiens et Canadiennes. Mais pour l'hiver, il faut continuer. Et aussi, le risque a augmenté si, avec l'hiver, il y a plus de monde qui se rassemble à l'intérieur. Donc, c'est très important de continuer avec les mesures de santé publique. Merci.
Emily, est-ce que vous... Oh, désolé, allez-y avec votre question de suivi.
Merci. Au niveau des nombres des signalements quotidiens de nouveaux cas, à votre dernière modélisation, vous parliez de 20 000 cas par jour à même 60 000 si les niveaux de contact augmentaient. On est rendu où maintenant dans les projections d'aujourd'hui pour les cas quotidiens?
Actuellement, on a toujours des données, on reçoit des provinces et territoires. Je pense que Dr. Tam et moi, on a dit que si la tendance continue, on peut même avoir peut-être comme 12 000 cas d'ici aussi le mois de janvier. Mais on a vu aussi que les efforts, qu'est-ce qui se passe actuellement dans les provinces et territoires, c'est une combinaison des mesures implanter des autorités, mais aussi les actions des Canadiens et Canadiens. On commence aussi à ralentir la croissance de cette épidémie. Donc, je pense qu'il ne faut pas seulement regarder qu'est-ce qui est possible dans quelques semaines ou dans quelques mois. C'est très important qu'est-ce qu'on fait, tout le monde, maintenant, aujourd'hui, actuellement. Merci.
Minister Hajdu, a few months ago, you said you were concerned about people buying their way to the front of the testing line, and we're going to get your department to look into that and make some recommendations. As far as I know, nothing happened on that. Now we hear that the NHL is or was considering buying vaccines privately for their players. Are you going to do anything about that? And do you think it's right that private corporations or individuals should be able to buy vaccines privately and use them?
Well, thank you very much. Listen, corporations always have the opportunity to procure equipment, supplies, tests, medication, and many do around the country. There are private benefits. For example, I worked previously with many trades unions that have private benefits and private services for their members. But what I'll say is publicly acquired goods will not be able to be purchased by private corporations.
So you're not going to do anything. It's okay if the NHL or some other businesses decide to buy crucially scarce vaccines on the private market and give it to their members or employees before other people in the general public have a chance to get it. You're cool with that?
Well, I think you're putting words in my mouth, but what I would say is that we don't have any mechanisms to block corporations from purchasing on a private contractual basis with corporations around the world. Listen, these are individual corporations that are selling to a variety of countries and selling to a variety of actors. I don't know the details of Pfizer's, for example, corporate contracts with other countries, but I will say this: anything the government of Canada procures for citizens will not be sold for a fee. We regulate. So I'm happy to turn to my colleagues in a moment, but I will just say this. The regulator's job is to ensure the safety and efficacy of the goods and products, including medication and vaccines. The regulator's job is not about access. It's about the safety and the performance of the products, making sure they stand up to their claims. I don't know if I've missed anything, doctors.
Thank you. David, would you like to go ahead?
Yes. Good morning, everyone. Thank you so much for joining us. David Thurton, CBC News. Just wanted to talk about the cases that we're seeing in long-term care. The data shows that they are rising. And so maybe someone could explain to us, how is it that after the horrors of what we saw in the first wave in long-term care, that these places remain so exposed to infection? I mean, I thought we learned the lessons that we were supposed to learn. So could someone just explain that to us? Like, what's going on there?
I can start, and then I'll turn to Dr. Tam. And I'll start with just the supports that we've given to provinces and territories to set the stage. During the Safe Restart agreements, $740 million of the $19 billion was set aside for supports for infection prevention control to help provinces and territories strengthen those processes to deliver on their responsibilities to people in long-term care. We've also supported with additional rapid response programs. As you know, we have, I think, I have a number here, as of yesterday, 401 Red Cross staff in Quebec, Ontario, and Manitoba homes. We've also shipped over 8.6 million rapid tests to provinces and territories, which some of them have begun utilizing as a screening tool for staff and potential infections that are presenting in long-term care. But I think it's an indication that we have a patchwork quilt, if you will, of standards across the country. And another commitment of the government through the fall economic statement was to create long-term care standards and support in part financially the provinces and territories to do that. And you're right, it's a tragedy. When we talk about the numbers of people dying, these are family members. I have a dear friend in Thunder Bay who just reported that her father passed away in Roseview in Thunder Bay just this week. These are people's fathers and mothers and loved ones who, in many cases, have many years of life ahead of them, actually, happy years of life ahead of them that have been taken too soon. So I know provinces and territories are having varying degrees of success of implementing infection protection control. Some of it has to do with, obviously, inspection regimes. We have an expert group that Dr. Tam and I speak to on a regular basis. And in fact, one of the experts is working in the jurisdiction of BC and talked about just the rigor involved to keeping COVID-19 out of long-term care homes. 24/7 process focused on many different aspects, including cleaning and screening. But the rigor is significant. And finally, the more community spread, the more of us that are infected, the more likelihood someone that works in a home will come into contact with COVID-19, and as we know, can be very mildly ill and can spread the disease to obviously really vulnerable people. Dr. Tam, did you want to add anything?
There really is not much more to add. I think, obviously long-term care is a complex environment within the jurisdiction of the provinces and territories, private sector. There's so many different constructs, and it's difficult to ensure, I think, that every long-term care home is sort of to the same standards and rigor. I do want to just stress the last point. One of the last points that the minister said is that if you have community spread, it's awfully difficult to keep it out of these homes, so which is why some of the support that everyone can do to reduce the community level of transmission, then we expect the outbreaks to be reduced as well. I think that many jurisdictions are beginning to do the testing and screening, so we'll see if that helps. The infrastructure piece, I think there's more support really going to long-term care because some of it is sort of long-term infrastructure pieces. Some jurisdictions actually have people in individual rooms, for example, and others have more than one person in a room. So I think there's some very varied reasons. But in talking to other chief medical officers, no matter how hard you try, if you got very much rapid growth in the community, it's really difficult to prevent them from the virus completely from these kind of high-risk settings. So, we just really need to be vigilant. But many layers and layers of screening and protection is what we're trying to do. Someone say, the Swiss cheese model where every layer is imperfect, but the more layer that each individual organization can put on, the better. And then we're here to essentially help and support.
Similarly, as we talk about long-term care, we could talk about what's happening in Indigenous communities. I mean, they were doing so well before in the first wave. Similarly, Minister Marc Miller, what went wrong there?
And it's an excellent point, David. Communities are fighting against odds that wouldn't exist in non-Indigenous communities. And as I mentioned in my answer to Dylan, we don't have to look at H1N1 where we saw the odds. It's a bit of a pale specter compared to what we're actually seeing in the U.S. in a number of communities. And if you compare communities, for example, the Blackfoot in Alberta and the Blackfoot to the south, the numbers are much greater. So there's things that worked during the first wave, but there's no magic to keeping COVID out of a community. It's vigilance, the adherence to the health protocols, tracking, tracing, isolating, making sure that communities have the resources. But you're fighting against, we're pushing back overwhelming odds stacked against Indigenous communities based on historic inequities, access to healthcare system, poor health infrastructure in communities, as well as the challenges that are faced in urban situations with respect to Indigenous communities, as we see the numbers in ICUs and hospitalizations in Winnipeg, for example. We constantly assess and reevaluate. I think a lot of the ministers that are in the mix and working every day to keep people safe wake up every day and ask themselves how they can move faster to help people. But COVID moves extremely fast, and when it gets into a community, when people let their vigilance down, when economies reopen, this spread is inevitable. But it is not. It is not a challenge that we can't overcome. There's some communities like Cross Lake, the military that went into Opaskwayak in their long-term care facility and did some amazing work along with Chief Christian Sinclair. There's amazing work being done in communities. There are other communities that are challenged, and they have to keep implementing their pandemic plans. Some of the measures that we implemented in Indigenous Services Canada in juxtaposition to what we did in the first wave of COVID are more tailored and addressing the inevitable surge. We knew this was going to happen, and we warned. We're still fighting those incredible, overwhelming odds, but tailoring those resources, including ensuring communities first have the financial backing of Canada, making sure they have physical resources, isolation units, repurposing common areas like schools and gymnasiums to deal with the surge. And extreme circumstances. And I would say, although every community has a pandemic plan, there isn't really one that plans for the arrival of the military, because these are really catastrophic scenarios. For example, as what we're seeing in Shamattawa in northern Manitoba, our approach from the very beginning is to ensure that Indigenous communities are not left behind. And there are unique situations to each community that make tailored measures really, really important. We'll continue to work with them, but this is going to be a couple, 3 or 4 or 5 difficult months as we see the increased stress on mental health during the winter months, as well as the challenges in overcrowding. And overcrowding is a huge issue. Every chief I talk to that has an increase in COVID in their community talks to me about the medical supports they need for their people. And the almost immediate conversation after that is about housing. Because if you have one person in a congregate living space that's multi-generational, you're talking about pretty much 19 or 20 cases if they have 10, 15, 20 people in that housing. It's an issue that COVID has brought to the fore. It has existed prior to COVID. We look at Inuit communities where overpopulation exceeds 50%. They have 300 times the rate of tuberculosis, which follows a very similar vector to what COVID does. So you asked me what went wrong. There was already a lot wrong before we went into COVID, dealing with the historic inequities, and those are the cards that were unfortunately dealt, and we're dealing with them. And that means deploying resources of the Canadian government to ensure that communities have the resources they need. That means constant communications with communities that have those spreads and adapting to the situation at hand, and in ultimate cases, bringing to bear resources that only the Canadian government can bring to the table, including the armed forces.
Thanks. We'll take another question from the phone.
Thank you, merci. La prochaine question est de David Aiken from Global News. À vous la parole, please go ahead.
Well, thank you very much, folks. I guess it's probably for Mr. Miller at this point in time. Just to come back to this issue of those Indigenous people, both First Nations members of a First Nation reserve living off reserve. And I think maybe the context for Premier Pallister's issue yesterday was there seems to be a fair public health imperative to prevent travel from people who are members of a remote reserve in northern Manitoba, but may be living in Winnipeg, from returning to their remote reserve in order to get a vaccine. Similarly, there will be First Nations communities. I think of the Tsuut'ina in Calgary. I think of Fort William First Nation next to Thunder Bay, Flying Post next to Nipigon. Those are next best things to urban reserves. They'll be able to get the Pfizer vaccine because Tsuut'ina is very close to Calgary. So I wonder, and I take note as well that Alberta's rules for handing out vaccines, their number 2 priority group in Alberta is simply adults over 65 in an Indigenous community. It's not Indigenous people in an Indigenous community, it's adults, and that would seem to make sense if you want to protect the community. So maybe you can talk about how you and the province are talking about trying to prevent or give incentives to make sure people are not traveling from urban areas to remote areas, and also being able to distribute Pfizer vaccines to those Indigenous people who do live and their reserves are very near a central facility for that vaccine.
David, I think Patty and I will answer this in parts. You're assuming a lot of premises to draw the conclusion that you're drawing that have various levels of accuracy to them. I think if you ask any First Nations leader, and I think they've been quite vocal about that risk of travel, it was one that is much lower than was presented. But clearly, the medical and moral imperative is to ensure that Indigenous communities are properly served by the Medicare system. When we start following the cascade of prioritization that exists in that the National Advisory Group has set forth, that requires an immense work in logistics and an immense cooperation with provinces. And when you talk about urban populations in particular, you see the limited effective ability of the federal government to implement its jurisdiction. I know Dylan talked about fiduciary duties, but we could get into a long conversation about the fiduciary duty to Indigenous peoples that are incumbent at the same time on the federal government as it is on the provincial government. But the point here, and I think this is important to remember, is we've got 2 principles here. The fairness of the medical system that all Canadians hold high. And then secondly, the importance of ensuring who does what in the most effective way. And that is a challenge in logistics that in large part, we've involved the Canadian Armed Forces to ensure that if there are mistakes being made, we're ready to pick up the ball and run with it in relatively short order. And that's what Canadians expect us to do. This is the largest deployment of vaccine in history, and Canadians expect us to deploy it in an effective way. We're talking a lot about jurisdictions, but what's important to remember is there are a lot of incredible civil servants working night and day to ensure this vaccine delivery vector, and again, assuming there are further approvals of other vaccines, is done in the most effective way so that all Canadians have the opportunity to get vaccinated. And we although those promising announcements this week are something to be quite proud about, we're not out of the woods yet. There are many months ahead of us, and if we look at the numbers, for example, and the projections that were brought today, there's a lot of things that have to fall into place before everyone has the opportunity to be vaccinated. And this is about fairness, and it's about ensuring that we have that prioritization established with provinces and territories, northern and remote communities, and in the case of the work I do on a daily basis, urban Indigenous groups as well. Patty?
I'll just add, David, that the national advice, the NACI advice on prioritization is being continually refined as we learn more about the types of vaccines and what they might be best indicated for in terms of populations. And secondly, that advice is being worked through at provincial levels, and the provinces will do the determination of how they prioritize within their own jurisdictions. We haven't seen indications that provinces and territories are going to abandon the NACI advice. In general, they understand the imperative that it is about saving lives. Those who are most at risk of dying from COVID-19 are prioritized. Those who are most exposed to COVID-19 are prioritized. And so I understand that it's a confusing time because, of course, as we see these first few doses arrive, we have a situation of sparsity, but over the next several months, all things considered and approvals forthcoming, et cetera, we have hundreds of thousands, if not millions of doses arriving. And the good news for Canadians is that everyone who wants a vaccination will be able to get vaccinated by the end of the year, of course, providing we get approval of these vaccines, et cetera. But we have purchased enough as a country, and we certainly have enough planning involved that we will be able to vaccinate all Canadians by the end of 2021, and maybe even sooner, depending on the manufacturer delivery dates and a variety of other factors that we at the Government of Canada don't control. So I think we have had a very good relationship through the various technical working groups, Dr. Tam's committee, and the variety of other folks that are working on immunization and vaccination. And I will just say that at the Minister of Health level, we also have had a very good relationship. And I'm confident that we will be able to vaccinate in a priority sequence that has the first goal in mind, which is to save lives and further than stop the spread of COVID-19.
Okay, thanks. I guess, yeah, the NACI recommendations have Indigenous communities sort of number 4 priority group. Alberta's got it number 2, Ontario number 3. So the provinces have made it, they put a much higher priority on getting Indigenous people or Indigenous communities safe. Anyhow, Minister Hajdu, question for you. Why not make the COVID alert mandatory, the COVID alert app mandatory on devices where the federal government has authority, i.e. all federal government workers, CAF, maybe look at federally regulated industries, banks, airlines, telecom. There's a lot of power the federal government might have to make sure that where it can do it, it puts that software on those devices.
Well, thanks, David. It's an excellent question for the former Minister of Labour. I would say that those conversations would have to happen in partnership with employers and their federally regulated unions, and I would be interested to hear the perspective of the labor movement, the federally regulated labor movement. As we've always said, this is a voluntary app that Canadians really should download as an extra tool. It doesn't use memory in any significant way. It doesn't drain your battery. It has been vetted by the Privacy Commissioner, and in fact, part of the Privacy Commissioner's notes was that it was voluntary and that this isn't a mandatory app for Canadians to use, but it is a very useful tool, and I would encourage people all across the country to download COVID Alert, even if you're in a province or territory who doesn't currently have the app loaded. You can still use it because if you come into contact with someone from another province who has received a diagnosis, then it would alert you in those cases as well. So I encourage all Canadians to download COVID Alert app today.
Thank you, David. And we have time for one last question. Please go ahead.
Dr. Tam, I want to ask you about Moderna vaccine again. Provincial and provincial and territorial authorities are talking about receiving doses of Moderna's vaccine. How close to approval it is, and how many doses these authorities, these provinces and territories were told they would receive in the first deliveries?
Just like with the Pfizer vaccine, we do a lot of pre-planning with a certain assumption, and with the assumption that it would get approved. We don't know yet, but all I know is my Health Canada colleagues are working day and night, 24/7, and so that I think one would expect them to have that analysis soon. But you would have to go back to the regulator because they are an independent reviewing organization. But I think that they are, as I think Dr. Sharma had indicated, very optimistic. They're working really hard. So then we plan ahead, just as we did with Pfizer vaccine. We know that we expect 4 million Pfizer, 2 million Moderna, if all goes well. So those are the numbers that we're working with. And as the ministers have said, the general principle is a per capita one. However, because the handling of these two vaccines is so different, the key is the consultation and discussion with the different partners. So as a result of that discussion, for example, the territories indicated that, look, the Pfizer vaccine just isn't the right fit from a logistics perspective, and that we would look towards the provision of Moderna vaccine for them. And because of the remoteness and the winter and the access, then they get forward delivery of more Moderna vaccine, up front, as it were, so that you're not sort of going in there more than once into remote communities. So those are the sort of feasibility and acceptability aspects of the planning, and so and then other remote communities as well, and that's why there is this sort of front loading of some of these remote access communities with the Moderna vaccine. The bottom line is the $6 million as a whole is a per capita concept. And so I don't know if that answers your question. Planning is well underway just to prepare the individual points of delivery, and the discussions with Moderna, like the sort of daily touch base, so that we know how to plan for that, just as we did with the Pfizer vaccine.
I want to also hear some of your thoughts on the sort of whispered lockdowns have been imposed in other countries and other jurisdictions like Germany, Britain, where they have seen, like us before, in the last few weeks, increase in cases, wide increase in cases. What are your thoughts on the efficacy of such move to improve, to impose a circuit breaker, a lockdown on the country for 2 weeks or more?
Yes, so I think, again, we presented our data, and each province and territory are in a very different context. And I think, locally or otherwise, they have to look at what's working and what's not. But, for example, one jurisdiction that did sort of turn themselves around a little bit in the last while is Manitoba. So we know what they did is we're beginning to see what is going on with the measures that they've taken. And I expect, given this kind of projection, other jurisdictions will be looking at what they may need to do more of. Alberta, for instance, just announced more measures. So that will take a little bit of time to see what actually happens, because it's just happened recently. But they, of course, looked at their information and figured that, look, hospitalizations and other indicators are trending in a certain direction, and this is what they need to do. But there is no doubt that reducing contact rates will get your curve down, and that's what the modeling is showing.
Thank you.
Glenn McGregor, CTV News again.
It's actually our last question.
One more question. Minister Hajdu, you look at those numbers, and they're pretty clearly a disaster. The curve, the projection cases is a hockey stick going up, and you're here talking about downloading an app and giving the sort of same message about moral suasion and washing your hands you've been giving for months. At what point does the federal government intervene, actually impose public health measures on the entire country? Is there a number of deaths we have to reach, or a number of cases? I mean, at what point do you actually start taking some real action on this?
Well, first of all, I would say that we've been taking real action since the introduction of COVID-19 to Canada. And I want to thank Dr. Tam and Njoo for working, and actually Dr. Wong, who's here, who I don't know as well, but who have been working literally around the clock to try and protect Canadians. But we do live in a federation, and we have worked collaboratively with provinces and territories. That has been our approach all along. We've been there for provinces and territories with money. 8 out of every $10 spent on COVID-19 has been federal money. We've been there for provinces and territories with tangible supports, including people, expertise, equipment. We've paid for all of the personal protective equipment, all of the testing, as you've recently heard, all of the vaccination, including the delivery and the logistics. We've been there for Canadians with economic supports to stay at home, with economic supports for reduction in business, with economic supports in terms of wage subsidies to keep as many people employed as possible. And as a matter of fact, Canada has been recognized for those efforts around the world. And yes, it is a tragedy. I completely agree with you that cases are rising. They are rising globally. There are very few countries that are not seeing growth right now. But I will tell you this, I believe it's that effort of partnership and that we will do whatever it takes attitude that will get our country through this. And I am counting on Canadians this Christmas to protect each other. These holidays are going to be very difficult, and I'm counting on Canadians to take care of each other and protect each other, because we can do it. We can do it for just a little longer, and we do see the light at the end of the tunnel, but we need to continue our hard work, and we need to continue to support each other, even if it's at a distance. Thank you.
Thank you. Thanks, Glenn. That's all the time we have today.